speak loud. Again, welcome, Cathy Meade from Moffitt Cancer Center, our final closeout panel before our final closeout by our two co-chairs. Just a reminder as we move into this panel, which addresses stakeholder perspectives and priority for the path forward. I think it's a good reminder of what really was this workshop all about and the overarching goal, which was to examine opportunities, methods, and strategies to improve the communication and information about cancer care across the continuum, as well as to address not only individual, organizational, and community systems. Over the last day and morning, we have heard a number of best practices, suggestions, and solutions. And as we move into our discussion on stakeholders, we have a panel of very illustrious stakeholders who bring a variety of perspectives, from the government to patient advocates, survivors, clinicians, researchers, and so forth, as well as all of you, which we want to gather your thoughts as well. A stakeholder, as defined when I Googled it, is a person with an interest or a concern in something. Obviously, our concern is that of health literacy today. With that, the way we'll work this panel is we will have no slides, okay? You like that idea? Each panelist will begin, and myself, with just a brief introduction of where we're from, what our interest or concern in health literacy is, and then to really put to bear and bring to the table a compelling issue in health literacy that they feel deserves ongoing attention. It may be an issue from the prior day, or it may be a new and fresh idea. Following that, I'll probably do another round of a question to our panelists, and then at that time I will call and ask for questions. And we hope to have at least a good 30-plus minutes to engage your stakeholder perspectives as well. And then probably towards 11:25, we'll conclude the questions from the audience, and we'll do our final wrap-up, hooray, take-home message from the panel. So this will be your last opportunity before we close out. So from my perspective, as I mentioned yesterday in my presentation, I'm a community-minded researcher with strong interests in communication, which were really rooted when I worked originally many years ago at a county hospital, noticing that health literacy was a prime issue and consideration, especially when people, as has been mentioned before, toss their pamphlets and information away. Also, it made me really reflect upon the disparity and the inequities that some people have access to information and some do not. Over my last 25 years at a cancer center, my laboratory has been that of the community and focusing on trying to bring mutually beneficial information and resources to our community members. And the lesson that I have learned is that community members, patients want information. They want to know about new innovations in cancer. We probably just need to do a better job to figure out how to convey that information and make them part of the table. So my message, persistent message, is inclusivity with a variety of stakeholders, and to really include the perspectives and feedbacks from our patients and our community members, because they will highly inform what the research will look like, what the education and training will look like. And it has been a very humbling experience to do that. And inclusivity will be my one message for today. So Sylvia, who are you and where are you from? And the last thing I asked our committee members to do is to do one fun fact about themselves.
Oh, I forgot.
Did y'all remember that? I forgot to tell you that, Rob. Okay, so you have ways to think about it. So I guess my fun fact is I like to walk, and my colleague back there, Gwen, and I walked and got, after the reception, 12,932 steps in.
Wow.
Okay.
Wow.
So we're good for today and have a few extra steps for did we walk? I don't know. We felt like we were walking a lot.
Oh, that's
okay. Go ahead.
All right, sure. I'm Sylvia Chow. I work at the National Cancer Institute. There's a lot of music in my family. I play the piano, and I have two kids that play French horn, piano, clarinet, and everything in between. So that's my fun fact. In terms of what, from a perspective of a stakeholder, I mean, our job is really to develop ways to incentivize and grow strongest multidisciplinary research in cancer control and prevention. So we can do this through writing program announcements, convincing the leadership and our stakeholders that a particular area is deserving of our attention. But I would also say on one side, I have a PD hat, program director. I talk to a lot of you. I review a lot of specific aims page, put myself in your shoes. How do we make this the strongest possible proposal? But really, the reason I have enjoyed my job so much is I believe in mentoring, and I believe in both being mentored and mentoring, new trainees. And to do that, we get to do a lot of projects. So I write I'm a very active writer, publisher in terms of ideas, and we don't have a lot of money to do our research, but still we can do a lot of nice mixed methods and qualitative, and using our surveys such as HINTS, Health Information National Trends Survey, to do research. So last thing I would say is I spent a year being a cancer caregiver, and that experience, I think now it's been a couple years, I'm able to better reflect on that. So the last day and a half, so much of the themes that have come up resonated with me, and I feel like we are ready to make I'm ready to, if I may, now make my 3 bold recommendations and observations. So 3 points. Actually, my mentee, the one that passed away, and I always found that 3 worked very well in these kind of closing summaries. So I always have 3 points. The first is I hear that we need to start moving from a top-down approach to think about health literacy to doing a better job at bottom-up, listening to patients, ascertaining and assessing, eliciting patient values and preferences. We have to not just think about what we can do to talk to the patient, but really listening to what their concerns are, what their information needs are, what their experience is like in this journey. And so that's kind of the problem statement. We need to move towards getting to listen to the patients. And it's kind of like the Elliot Mishler's idea of the voice of the life world, meeting the voice of medicine. How do we bring the life world into the way we do care? To do so, I have a couple of bold ideas. I think we need to embed in our training better listening and skills. We need to incentivize empathy. How do we make sure that providing empathy, providing listening is something that's valued, that adds value? We need to work with the right stakeholders, patients, caregivers, to think about how to, and anthropologists, people who do CBPR, user-centered design, to really get at that patient and caregiver perspective, navigators. And we need to change the workflow, routine workflow in the clinic. We talk about distress screening. It's a wonderful thing to know where patients are. But if you've just found out that your cancer has spread all over your body, you're sitting there having scanxiety because you just had a scan, and someone asks you, please, on the scale of 0 to 10, how sad are you? I mean, I was there multiple times, and it's such a ridiculous question at that point. And then you go into the room, and people ask you 100 questions before you can find out what happened to your latest scan. And that is really not patient-centered. So that's my first point, is how do we do bottom-up health literacy approach? There's one more solution there, is we need to really build on teams and the expertise of the teams. And I don't need to repeat what I've heard in the last panel, and I'm sure everyone has good ideas of how to bring social workers, nurses, navigators better into the way we holistically think about health literacy and cancer. Secondly, the open mic nature of online communication has meant cancer information has become ubiquitous and mixed quality. So we need to think about the increased complexity and confusion that can cause patients and address them. And yesterday I already sort of outlined some of the approaches. I would only add there that we need to include industry partners, people who are purveyors of social media platforms, and the policies regarding addressing misinformation together with partners in the industry. And the third point is kind of an old point. I think we all are here because we care about health literacy because we care about serving the needs of those who are vulnerable, whether it's because you have just heard that you got cancer or that you are an immigrant, English is not familiar to you, or that there are so many reasons. Health disparity underlines everything we do. And we know this is a time of tremendous division and bias, racism, sexism. You don't need to, I don't need to say more. There's just, rampant amount of, bigotry and xenophobia. So I think this is not a time to really go too esoteric, but it's so urgent that we keep doing what we do because we are there for the people who are vulnerable and for those who may not have a voice at this point in time in our history. So we need to think about policies and practices that put equity first, and that we need to pay extra attention and sense that increased urgency for working with our limited English proficiency immigrant refugee populations, underinsured or uninsured populations. So those are my 3 points.
Thank you, Sylvia.
Get extra 1 minute later.
No, that means you're over. Actually,
oh my gosh,
that's really that's really aggressive. That thing that's
so I was
yeah.
1 minute over.
But it's a good font size.
It's a good font size. Yes, it's a good font size. Well, that's the perfect segue because I actually started at my name's Gwen Darian and I lead patient advocacy and engagement at the National Patient Advocate Foundation and the Patient Advocate Foundation, and I am a longtime advocate. I've known some of us were trying to figure out how long have we known each other? More than 20 years, what I've mostly done, and I'm a 3-time cancer survivor. I'm a young adult cancer survivor, and then had two cancers as a middle-aged woman that were likely caused late effects of the treatment that I had for my first cancer. So I come at this from multiple different lenses. I come at it from the lens of somebody who's worked in advocacy for over 20 years, who is my focus on advocacy has always been at the intersection of touching people and system change, and that's what I do now, with a very, very clear focus on disparities and communication. And I come at it from the perspective of a cancer survivor and also a cohort. There are a number of us in this room who are young adult cancer survivors. Deb, Ivis, we all were young adult cancer survivors together who came to advocacy, and then a number of us are having second and third malignancies that might be related to the cancer but weren't really thought of before. So in my current role, and our team and 2 members of my team are here. Jamie Trotter and Ashley Freeman. Our role is to take what we learn from the patients we serve through direct patient services at Patient Advocate Foundation, where we serve 150,000 patients a year who are having trouble accessing quality, affordable, equitable health care. They are primarily low income, and they all have serious disease. And that bridge between that and system change, and how we can help change the system to help alleviate those barriers and those equitable barriers. And I think, building on what Sylvia said, it is not even an elephant in the room; it's a stampede in the room about what is going on in terms of treatment and the healthcare system and access across many different communities, and it is getting worse and worse. So I was thinking a little bit about, there's so many different ways of approaching this conversation, and some of the people in the room who know me know that the first 2 things I did with my advocacy work, because I started out in the contemporary art world, were 2 magazines for people with cancer. The first was Ma'am Magazine. Ivis was actually profiled in the first issue, and then on the cover of our first anniversary issue, I think, Ivis Sampaio. And the second one I did when I was at American Association for Cancer Research. And so my focus has always been about communication and building bridges among multiple stakeholders, but also thinking about what literacy and understanding meant. And I want to push back on some of these ideas of how we frame literacy, because literacy is about communication, and communication is about trust. And to go down to the solution of health literacy without addressing these ideas of trust and communication, I think that we're starting in the center as opposed to starting in the beginning. And I think that the other issue here is that it's not about grade level of communication. What it's about is it's about clearly communicating in a way that is a dialogue, and clearly communicating without jargon, because it's jargon that distances the patient. It's not, when you're a patient, you have an incredible motivation to learn many things that you never wanted to learn before. But it's the jargon that's the distancing. It's not the grade level that's the distancing. And people, as long as you define terms, and this is what I did in the magazines that I did, we always defined terms. We always helped people understand what concepts were, and we would always be there for questions. It was a dialogue, but it wasn't about dumbing down anything. It was about making sure that we were speaking in a kind of language that different people could understand. I think the other issue with trust, which I brought up a little bit earlier at the microphone, I just did an article with two colleagues that was in JAMA about trust. It was part of a trust initiative that ABIM Foundation is doing, and our contention was that trust had to start. One of the ways to start trust was by the physician or the healthcare provider initiating and trusting their patients. So much of what we talk about is building trust from patients for physicians. We talk about systemic racism and structural inequities, but we don't talk about the fact that that comes from the other side as well. And often it's the physicians and the healthcare providers who have to start and initiate that trust to allow their patients to trust them. So I am actually over time with that red light flashing at me. So the fun fact, actually the most fun thing I did recently, one of the I was never able to have kids of my own, and I found an incredible partner and he had incredible children. And so I was able to have a family through marriage, and we just got back from China. And the trip to China was actually inspired by our 24-year-old son calling us and saying, "There's a great deal on Delta. Do you guys want to go to China together?" So the idea that I have now coming from somebody who thought that she'd given up her possibility of having kids to having a 24-year-old who said to me, "Can we go to China together?" is just beyond what I could even imagine. So thank you.
Okay, good morning. I'm going to see if I can do this in 5 minutes or less. My name is Darcy Graves, and I was asked to wear two hats during the course of this presentation. One is my patient hat. I am a cancer survivor, and I'll talk a little bit more about that later. But professionally, I am with the CMS Office of Minority Health. So my lens of equity, social determinants of health, and health disparities runs strong, and it's been thrilling to hear so many people talking about that for the last day and a half. So I'm going to segue right into kind of my, Sylvia had three. I have two key takeaways. Everything we do could, should, and needs to be more culturally and linguistically appropriate. And we don't necessarily need more of any of what we're doing, but we need to do it better. So when we're talking about big C communication, marketing, screening guidelines, education, clinical trials, or if we're talking about little c communication, when we're talking about prevention, diagnosis, treatment, survivorship, palliative care, social work, any of those interactions with someone who works at a healthcare organization and a patient or consumer or family, all needs to be more culturally and linguistically appropriate. So how do we do that? Well, I always argue we need to bake it in everywhere. You don't need a 45th manual that says, this is our action for culturally and linguistically appropriate services that includes health literacy and communications. So no, when I say culturally and linguistically appropriate, I mean that includes health literacy. We don't need a separate one. We need to put health literacy, we need to put cultural competency, we need to put language access into those existing 45 manuals. Everything can be made more culturally and linguistically appropriate if we add that lens. So how do we do that? We consult the community. As they say in the disability community, nothing about us without us. We are not the saviors. We are here to work with our communities to help them achieve their highest level of health. Use the data you collect. We're sitting on mounds and mounds of data, but we don't always have the time, the knowledge, the bandwidth, the capacity, what have you, to go back and use that data to inform what we are doing. Stratify it. Stratify it by race and ethnicity. Stratify it by geography. Our urban populations are not the same as our rural populations. And as they say in the rural communities, when you've seen one rural community, you've seen one rural community. So, we have to look at how we're structuring these messages to the different populations we serve, because we're not all weird. We require special kinds of lenses. And if you don't know why I said weird, look at yesterday's recording. So if you don't have the data, figure out how to collect it. But be sure that when you're talking to your community members that you're collecting it from, that you tell them why you are collecting it and how you're going to use it. Because just to say, can you please tell me your sexual orientation and gender identity, is not sufficient. They need to know why, and they need to know that they can trust you. And then, of course, training, not more training, but informed training, integrated training that includes health literacy and cultural and linguistic that is culturally and linguistically appropriate. So all of that said, and then we've talked about so many amazing advances in the last day and a half. And every one of them is important. But we have to make sure that we don't lose sight of the fundamentals of communication and health literacy. And that brings me to my patient perspective. I am a self-described patient of privilege. And that's strange coming from somebody who is a breast cancer survivor, who has undergone a double mastectomy, 16 rounds of chemo, and a prophylactic bilateral salpingo oophorectomy. But I am a patient of privilege. 6 years ago, next month, I was diagnosed with breast cancer. When I was speaking with my radiologist, who was doing the MRI or doing the ultrasound and all of those things, and upon confirming my tumor, looked me in the eye and said, "We can biopsy it or we can monitor it. It's really up to you." And I took a deep breath and I said, well, in my chart, it indicates that I have a long family history of breast cancer. So even with that knowledge, we should monitor it. Oh, family history, tell me about that. Don't communicate if you haven't read the chart. Please and thank you. Because I'm glad we reconsidered, because 3 days later, he called to tell me about my stage 2, grade 3 tumor. And when he called me, I was on the phone a couple of hours later with my gynecologist's office trying to figure out what the next steps were. And obviously I still had, you have cancer ringing in my ears. And the nurse who I was talking to on the phone, in her most calm and soothing voice, said, "Don't worry, breast cancer is a slow-growing cancer." That may be true for some, but it was not true for me, and it is not true for most of African American and Hispanic women who tend to get triple-negative breast cancer. When they talk about proliferation scores, they consider 30% to be high. Mine was 90. If I had taken that time that she said that I had to process the information, to think through, to talk to my family, to digest, to do research, my outcomes could have been so much different. It was only because I was health literate and challenged my radiologist, and it was only because I was health literate and didn't listen to the nurse that I'm sitting here today with the outcomes that I had. So I didn't make my 5 minutes, but patient-centered care needs to be culturally and linguistically appropriate. We don't need to do more, we just need to do better.
Did you have a fun fact to share?
I was once ambushed by monkeys.
And where might this have been? Where might this have been?
I was in Japan.
Okay, we'll leave that. The story will be told later.
that's what I've found too often is the patient has to be their own advocate against medical advice. My fun fact is that for years, apparently, a large group of my students, former students, thought I was married to a Black Panther. So you sort of know my political persuasion and being from Berkeley, and I didn't find out till I was an adult that Berkeley was redlined, and that's why I lived in Kamala Harris's neighborhood before she was there. So it's a long process, and being able to speak the language of and I had more comfort and I think effectiveness working at San Francisco General than I did during my training than in the private hospitals. What I learned in school worked at private hospitals in communication, but what I learned at home was what worked in the county hospitals. So they're different worlds, they're different languages, but I think one of the key pieces that's wrung out of every helping profession in the health field is listening. We don't take the time to sit back and actually connect with the person we're talking with. They're scared, they're in the hospital, it's a new world. They have no clue what's going on. They don't know you. They don't know anybody in the hospital. And too often, the doctor only talks to the patient. But cancer is a family affair. We've heard that from several speakers. And yet, we don't address the unit. And that family can be defined quite differently from person to person. One of my colleagues is a physician at UCLA. She and her partner had been together for like 15 years. The partner's in the ICU, critically ill. She's the partner. She's not allowed in because she's not legally married. You know, these kinds of rules that we have go against the humanity that we're supposed to be addressing. And could you put up slide 38? I break rules all the time, but so far so good, and I do it with people who are very forgiving. One of the things that those of us who do research with community members is to give back the data to the community and help them use it in the ways that they think can best serve their population groups. It doesn't do any good in my files, but it can do good in helping them. One project I worked on, we had all these forms for the community advocates to fill out, and they go, "There are too many." Sorry, that's not the one. It's the slide with "listen" on it. Keep one back from there. That one. And he said, why do we have to fill out all these things? It takes so much time. I said, okay, these are our measures of success, that we've accomplished what our goals were for the study. I said, I want each of you to write out your goals and definitions of success for this program. And they did. And then I said, okay, write up the questions you think you need answered to know whether you've gotten to your goal or not. One of them was to increase the phone calls to the agency from their community groups to ask questions about breast cancer. And so they did, and then it ended up, instead of the one page that we had, they ended up with like 5 pages each. I said, okay, you want to add that to the group? Because it's important for them to have data too. And that's building the capacity of our partners to be able to do the research they want to do, to answer their questions for their communities. And for those of us who work betwixt and between, I think that's our role as well. My goal was to work as a community advocate when I finished my PhD. And then I literally sat in my office at UCLA going, how did I end up in the enemy camp? And what I found out was it was my role. It took me about 5 years to figure it out, was to teach the new students how to ask those questions. And what's up on the slide is the Japanese and Chinese character for listen. But those of you who are clinicians, this is what we're supposed to be doing. Yes, you listen with your ear, but you listen with your being, your eyes, your undivided attention, and your heart. And when any clinician listens to their patient in that way, the trust, the bond is built, and you can go forward as a team with the patient. And they can express things to you where they need the treatment modified because of what's going on in their lives, but they know that you're always with them. And that link is challenged. The physicians are way too busy. How can you have these kinds of conversations that we're talking about here in 15-minute encounters? I mean, that's inhuman. You know? And it's harder, I don't know, it distresses me to see so many young clinicians dropping out of medicine and going into something else because they just get so frustrated. We're losing the best and the brightest because of a systematic toxicity. As we go forward, the horizon of new treatments is just mind-boggling. I'm so excited. It's like science fiction of what's going on at the genomic level. But what's the price tag for those treatments? Who's going to pay for that? Who's going to be the recipient of that? Are all of those folks who are of low income, low literacy, going to end up with standard care, and the fancy care goes to those who can pay out of pocket? You know, and even that's cancer is one of the most common reasons for bankruptcy. And this is for people with money. So how are we going to address all of these? And I'm hoping that, you know, with the brain power and the passion that's in this group here, you know, what kinds of new avenues, new paths can we forge to make a difference for the populations that all of us have gone into our fields to do and to serve? And that's the other part, is the idea of being of service to someone and not a monetary exchange. In that way, we give of ourselves. So I still have time, so we'll continue. You're over. Oh, they over. Oh.
Thank you, Margie.
We have all been over.
Okay, we're moving down the row here. Okay, Claire.
Good morning. Claire Saxton. I'm the Senior Director of Education and Outreach for Cancer Support Community. Fun fact about me, I live right near NIH in Bethesda, and I work almost next door to the White House. And I get to bike to work about once or twice a week on this incredible trail. It's an urban forest trail that leads all the way down to the Potomac and then to the mall. I get to bike by the Washington Monument and then by the White House on my way to work once or twice a week. So, fun fact about me. For folks who don't know the cancer support community, our mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. We provide direct services, both through our local cancer support communities and Gilda's clubs across the country, and as well as support and education on our cancer support helpline, our My Lifeline online support platform, and education through our web pages. We also have a Cancer Policy Institute that focuses on the things that are most important to people affected by cancer: quality, access, research. We also have a Research and Training Institute, which is the largest nonprofit oncology psychosocial research institute in the U.S., and it focuses on the experience of cancer patients and caregivers. In my position at Cancer Support Community, I help oversee the patient education that is given out through our centers and also used by quite a few small cancer centers and oncology practices across the country. One of the things that we always try to focus on is what are those psychosocial impacts and how do you help patients and caregivers cope? One of the things that we policy-wise push for is distress screening, and the follow-up to that distress screening of appropriate services to help people where it's most needed, because in order to get to a point where you can even think about understanding what are the next steps, what's going on, you need to be able to get past that fear and get past logistical issues and financial issues that are getting in your way. And so there's so much that I want to say about what both Cancer Support Community and other patient advocacy groups are doing to help patients and caregivers every day. But I think one of the things that I want to give as an example of why we need to include patients and caregivers in every step of the process is our Research and Training Institute just came out with a new tool in the last year, the VOICE tool, Valued Outcomes in the Cancer Experience. And what they did to build that tool is they talked to patients and caregivers about what does value in cancer mean to you? Because there's this whole academic conversation happening about value. And a lot of that conversation has to do about the equation between benefits and financial cost of treatment. But when you talk to patients and caregivers about what does value mean to them, what they say is value means quality of life, and value means the communication and relationship that they have with their oncology care team. And that is what value means to them. And if we're not including the patients in everything that we do, whether it be building educational programs or looking at costs and benefits of treatment, then we're missing the boat. There's a lot more that I hope to talk about in the conversation that we'll have, so I guess I'll just stop there for now, and very interested to hear your information.
Claire, I just want to say you were right on the money with the 5 minutes. Okay, we're going to send it down to the end of the row, Dr. Winn.
Yeah, unfortunately, I'm going to try to do that, but we'll see. Fun fact, I'm Dr. Winn. I'm the Cancer Center Director at University of Illinois Cancer Center and the Associate Vice Chancellor of Health Affairs for community-based practice. Long-winded way of saying I oversee a network of 13 federally qualified health centers. The big dream for me is actually the integration really of the community information that really directs what we do with our patient care, what we do with our screening, and how we do our research. With a couple minutes, I'm going to sort of emphasize a recurrent theme of the need to see humility as strength and why we need to call on that right now. And the second one is the fact that connectedness is power. And we have to actually understand that as we're pushing the envelope around data and technology and these big academic sort of themes, and we're actually also really granulated looking at the individual almost down to their single cell, we've actually missed something very important, that's community as an identity. What do I mean by that? Yeah, and recently, I think some of you have also read the article where we looked at the issues in Chicago, that there is a 30-year gap between two neighborhoods that literally are to the east of me 3.5, 4 miles away, and to the right of me, really about 5 miles away, that in my Inglewood community, which I have one of my federally qualified health centers, the life expectancy there is 60. Whereas in Streeterville, which is not that far away, Gold Coast, as most of you might remember, or the Loop, it's 90. The issue is we're talking about all the stuff around precision, around individuals, but when we start talking about communities, it's as if we blanket these communities and they lose their identity. We inadvertently make them invisible. Why is that important? I think as we talk about literacy, it becomes important to know that it's not just literacy at the individual level, it's at the community level. I was struck when I was in Cuba, and I know, not to be provocative, but it's just the way it is. I can tell you when. It predates this. Anyways, it was under the Obama time. I'll just say it that way. One of the things we actually had was not the concept of going to Cuba just to learn, but to actually also we did a program in which we brought a group of Cuban docs and healthcare providers from Cuba and embedded them on the south side of Chicago in one of my clinics. And the exercise there was to sort of say, if you were to come here, what would you do? How would we do things differently? How would we see things differently? And one of the things that one of the first docs says is that it's interesting. Doc, and I don't know how to tell you this, but one of the things we sort of see is that there is no connectedness to your providers, to your community. In fact, your docs may know the episodic events, but they don't know the universe of your community in which they serve. So data really is powerful. The second point, and I only got 2 minutes, is that we talk about literacy a lot, but I did an experiment in which I had a community mentorship program that I started. Now, from the sounds of that, you're thinking that we're mentoring the community. It's not the program. I actually took leaders within our community and paired them up with our associate directors, my senior leadership of my cancer center. Why? I did that specifically because they were being mentored for the year about not only what issues were important in the community, but how to communicate them. And in fact, in the words of an 87-year-old to one of my best basic scientists, she goes, Doc, I don't know how to tell you this. That man might be smart, but I don't know what he's saying. He ain't gonna make no sense to the people. So there is a sense of literacy also, bidirectionality of literacy, that if we really want to push the needle, we also have to become much more literate about the issues within the community to be able to push. Why is this important? Because if I just talk about African Americans in Chicago, I will lose the fact that Inglewood, with a life expectancy of 60, is very different than my crew in South Shore. The issue of making and seeing not only people, but seeing communities, and getting back to seeing communities, I think is really at the crux of what we don't talk about, we typically skim over, but that's going to be in the 21st century. How do we use the data to do that? Why is this important? As a lung cancer person, if I show a person their CAT scan, and I always start off with showing them their films, I say, this is like your family, this is a picture of you. If they see a spot at the bottom of their right lung, whether they're in second grade or whether they have 2 PhDs, there is a connectedness at that moment to what's being transpired, right, and what's being shown. How do we do that with our communities? I'll end with also sort of saying that the reality is we are very good now at community outreach engagement. I call that my Army Corps of Engineers and my sort of special forces of good, which I'm going to call my scientists of doing things. But the interesting thing is battles are usually won and lost, whether you talk about Bunker Hill or Chancellorsville, in the context of intelligence. Where's our recon unit, and how's that recon unit providing work within the communities to be able to better inform us as researchers and better inform, again, the community about what's going on? I know that this sounds crazy, but that's where I am. And I guess fun fact would be that back in the day, I still have my wheels of steel, so to speak. But back in the day, I produced hip-hop music with Mos Def and folks, Black Thoughts from the Roots and things like that. And occasionally, I still have my Techniques 1200s for those of you who've been around. And I actually embarrass my kids by sort of saying, come on, you want to, like, throw down? And they're usually like, no, Dad. But anyways, I'll end with that. Thanks.
Thank you very much. I think you can tell our stakeholders have passion, they have drive, they're artistic and musical as well. So, and part of that is just what I think every panelist has stated, that there needs to be a connection, some type of a relationship as we communicate this very difficult and often very frightening information, especially if you're being told that you now have a cancer diagnosis. I've been in the field of health literacy for a long time, And I've always felt that at the heart of health literacy is truly communication. It's in some way it's not fully rocket science, but we've somehow some way got off the trail a bit in trying to think of how to measure it, what to do with it, and all of that. But at the end of the day, what's really important is a one-on-one conversation that I have. And let me just reiterate, and I'm going to do just like a brief 1-minute summary, and then I think because of our time, if there are questions, you can begin lining up now, and we'll move to the questions because our panel will close sooner than we probably realize. Key points are the focus on inclusivity and also the ability to talk and to listen. I often call this the concern for conversation. How can we embrace conversations, build trust? How can we also bake in culture and linguistically appropriate information? A couple terms I heard from yesterday is how do we make information alive and how do we make it authentic versus listless? And I think that is really our challenge here in the field of health literacy. How do we add value to our communications? We must include stakeholders. We're just a sampling of the many stakeholders that can really address this problem, but we need to be much more expansive. A wish list would be to have some type of a national, perhaps consortium, that could begin to look at this so that our communications are lined with humility and connectivity, and they're embedded and they come from our community. So with that, I'd like to see if there's some questions from our other stakeholders in the audience, and then at 11:25 we're going to come back to our panelists for the last hurrah. So you've got time to think about what's the last hurrah you're going to leave with us. Questions over here?
My name is Bradley Randall. I'm a family medicine physician. I trained in Contra Costa, California for my residency at a hospital there. And I'm also a cancer survivor. I have brain cancer, 5 years out. And I have a very broad question, but like I'm sure you all have reflections on it. As I've listened over today, I wasn't here yesterday, I've heard a lot of references to the system and structure and policy and rules. And as I reflect on my experiences, those matters came up a lot. But to me, I saw them came up against issues of legality and the law, and I just haven't heard that in the discussion. And so I'm just very curious about how many people here have a legal background and how much conversation is in that, and your reflections on that. I mean, in terms of advocacy limits and access to things in health, including like money, debt, like, you talked about people being, and this is something I came up against, and debts and like trying to deal with that from a legal perspective. But of course it's medically related, and everything I've heard is medically related, but I see legal aspects to it too. So I just want reflections on that.
Sure. So I can't address it entirely from the legal perspective, but I can certainly address it and actually this was going to be one of my closing comments about cost and about access. And I was thinking also about what Darcy said, and we had a conversation yesterday about the incredible financial impact and burden, and Marjorie was talking about the burden of treatments. Cost affects everybody, and if we ask our patients one of the top things that they want to avoid is financial devastation and financial ruin, even more often than outcomes in terms of their treatment. We had a patient who talked about how he quit treatment because he couldn't afford to live, and there should never be a time when somebody has to quit treatment because they cannot afford to live. This is not an appropriate or acceptable societal approach to health, and we know that we have some. There is still not widespread agreement that healthcare is a human right, not a privilege. But there are also resources for people But one of the problems is that the people who access the resources tend to be people who are already resourced. And they don't necessarily, it's not that they have financial resources, but they have the wherewithal, they know where to go. They can, even in the midst of crisis, they can actually think about how to come out of that crisis. So I think one of our challenges is to make sure that one of our challenges as a group, and Marjorie was talking about this, what we need to do as a group, is understand how we can address these issues for everyone and make these resources available for everyone, not just those of us who have access to those resources. I will say personally, when I was diagnosed with cancer at 35, it took me years to pay off my debt. And it wasn't medical debt, because I actually paid for my treatment. It was everything else that went around that took me years and years to pay off. This last episode, I still have medical debt on my credit cards, and that was medical debt. And I have a very good job. I have very good family support, but even an episode of cancer that isn't that expensive can be financially devastating. I think there are a few, and I am not the legislative person on our team. I do advocacy with a outside the Beltway definition, which is not at all about legislative advocacy. But there are a number of bills that are out there to try to alleviate this. There's a bill to separate medical debt from other kinds of debt. There's a bill to not put something on somebody's credit report until medical bill until all of the communication is resolved, as opposed to reporting immediately. And I think the other thing that's really important within that context is that medical debt is not an indicator of people's credit worthiness. So being in medical debt has nothing to do with how you are going to deal with the rest of your lives, although it impacts all of the rest of your lives. And one of our advocates, I remember her telling us that she wasn't able to buy a car. Some of the most simple things that you need for daily living. So that was a long way of not answering your question directly. However, what I would say is that it behooves all of us to help people and facilitate people finding resources to help them financially and help them with these issues and help them with their insurance issues. Patient Advocate Foundation is one avenue. As I mentioned, we help 150,000 patients a year. There is no income line. There is no income test. We just happen to help people who are more underserved and vulnerable. There are multiple other organizations that have help and have financial help, and there are a few foundations that also do legal work and work on the legal issues. But the most important thing we have to do is facilitate access. We facilitate access to all these different domains across our experience with serious illness as patients, as caregivers, and as members of society.
Thank you. So just to add to the comment about legal, I think the legal stakeholders certainly could play a role in this as well. Especially when we should question a consent form that's 30 pages long. So, a lot of cancer centers, they have a whole legal team. They need to get involved and explain. We sign memorandums of understanding with our community members that have these paragraphs that make absolutely no sense, and we have to question things like that. I'm going to move to the next question.
Hi, thank you to the panelists for an excellent panel. Really inspired yesterday and today by all of the presentations and questions focused around health literacy and cancer care. I'm Arti Varanasi with Advancing Synergy, and we're focused on developing and moving forward innovations that can really empower individuals and impact the community. So a lot of what was shared on the panel today, and one of the things that keeps me awake at night, Dr. Singer, is exactly what you were talking about. We are an exciting time in cancer care and treatment with new innovations just coming up every day. I actually started out as a bench scientist and in actually lung cancer research and left, and now found myself in this new area of technology and digital health, because I was like, if I'm working, and I was working in an exciting area, cancer immunotherapy, right? So if I develop a new cancer vaccine, how do I know that the people that need it most is actually going to get it? Right. And so that's what kept me awake at night. And I thought I could maybe make a bigger impact in another realm. But the challenge has been, and this is my question to the panel, is connecting with individuals and being out of kind of your comfort zone. And everybody's busy with their day to day and kind of in their own swim lanes, but they're not necessarily connecting with each other when they need to be. So how do we take the conversations we had here and share them with the broader community so that we can really connect at points and support each other? Because I feel like there's more than enough for all of us to do and have, a piece of the puzzle to help really make a huge impact in cancer care control and really change patients' lives and their caregivers. And I also, speaking as a former caregiver as well, my aunt was diagnosed with metastatic breast cancer, and I helped her get on a clinical trial at NCI, and that was almost 15 years ago, but I still feel the impacts of being her caregiver. A lot of it I never realized until, sometimes when I'm in situations like this. And, Darcy, thank you for sharing your story, because that is what I've seen too with some of the patients I work with, right? With cancer, you have to make some very difficult decisions very quickly. And so how do we help empower everybody in that system to do that better?
So in short, how do we take this information and spread it to another group?
Yes.
Who would like to take that? Okay.
Sure, I'll give it a first try. One thing that I would challenge everyone here to do is to think about how we can work together across those lanes. One example is how lung cancer advocacy organizations are getting together and pulling in industry partners, groups that educate healthcare providers, other patient advocacy groups, and looking both in lung cancer and then across all different kinds of cancer. How do we talk about some of these new innovations so that they're not hearing one term from industry, another term from their doctor, and another term from their patient advocacy group, and thinking that these are three different things that they need to learn about when really they're just talking about one thing? And how do we work together to make sure that we really are communicating simply and clearly? Because do patients need to know whether they are, need to get a proteomic test versus a genomic test? No, they, on a basic level, lung cancer patients should know that they should ask, have I had EGFR and ALK testing? Something as simple as that. Right. I mean, at least simpler messages.
Most doctors
Yeah.
in America would not know the answer to that question.
Yeah.
Most doctors in America do not know the answer to that.
Yes, and that's a problem, especially as the as standards of care and guidelines change, and the doctors aren't even well informed of what the standard of care should be, and so that actually, not enough education to doctors and the whole multidisciplinary healthcare team means that there's an extra burden put on patients to figure out what are the guidelines and what should my standard of care look like, that somebody who isn't well resourced will never get to that point unless they have incredible navigators and support advocates helping them along that journey.
I'd like to add to that real quick that a couple things. This is not going to sound so sexy, but there really is this commitment to actually understanding. When I say community, I'm not just talking about the people living within it. I'm talking about the physicians who are practicing in it. I'm also talking about the political folks who are actually being like their aldermen that are being able to do things. And again, when I talk about a community unit, I just want to be clear that once you actually understand the parts of the community, because your question is, well, how do you get them more involved? Part of that is your dissemination. This is one of the reasons why we have a radio show, which I know is not super sexy in the 21st century to have a radio show, but it turns out that most of the people on the south and west sides of Chicago are tuning in on Sunday to something called WVON, which has actually been they call it the voice of the nation, but it's been around since the 1950s. So there's a culture. So go and meet people. Second, you actually have to have the humility of going to someone else's house as well. So people say, well, why don't these folks come out to, this wonderful thing on this molecular targeted therapy? It would be great for the community. And, one of the community members actually just turned around and said, when the last time you was in my town hall? When did one of y'all people? So we started actually doing this program in which I'm now had to do myself and my senior leadership team are going into communities for their town hall, showing up in a consistent way that we care about the topics in your neighborhood. You know what that's actually resulted in? That's resulted in, for example, when we get great speakers that, like we had even yesterday, which is why I couldn't be here, a third of that audience were from people from the community. So the truth of the matter is, you can't do this without actually having a ground game and being sort of a contact sport. We're trying to win this game sometimes by informing everyone with this 30,000-foot sort of approach, but it ain't going to happen in all neighborhoods, right? So we have to have a different approach, and I'm going to go back and sort of say that I love technology and all of what it's going to do, but what I'm afraid of is that my guys in Streeterville will go to 95, but the folks in Inglewood will still be at 60 10 years from now. Exactly. How do we target not just through technologies, but actually being on the ground and getting back to, I know it sounds like kind of 1960s, 1970s, maybe hippie-like, but how do we get reconnected to our communities, and not just the people within the communities, but seeing that the people in the community also are your primary care docs and your community oncologists who really feel invisible in some of our discussions. Right. So I'm stopping.
We're getting short on time, so I'd like to get to next question and be very concise in your question.
Okay.
And concise in your response, and we'll do the last three here.
I'm Latina, I speak fast. Okay, so I'm Ibis Sampaio from SHARE in New York City, and I wanted to thank all the presenters today. And I think what is coming out of this is that we need to work together. Part of what we do at SHARE and other organizations, as we do with Gilda's Club and other, is share. It's a collaborative effort. Stop the competition and instead work together and put the patients at the very face and forefront of this. I've asked for my last slide to go up. Those little boys up there were the two little boys that I had to look at 25 years ago when I was diagnosed with breast cancer. I didn't get to mention when I spoke before, that's what kept me going. Being alive, I told my doctor, I can't afford to die. I've got 2 kids to raise. But most importantly, you have your patients. Don't see it as X, Y, and Z. Remember, it's Ivis, who had 2 little kids, who was too sick to be able to take care of her 2-year-old, who her 10-year-old wound up with emotional asthma because his mother was losing her hair and going through all that she was going through. But also, remember that my goal was to do what I've been able to do there. Look at those faces. I am dancing at those weddings. I danced at those weddings, and now I'm the grandmother of Gwendolyn Mackenzie Sampaio. So keep that at the forefront of everything that you do, because in the end, it's not about just the structure, it's about the patient. It is about the human being that you're connecting with. Thank you.
Thank you.
Okay, just a couple comments of other things. This has been great. We've had a lot of really good ideas. A couple of things that were touched on but not really focused on that I think we need to bring into the discussion as far as the solutions are. What we're talking about really is helping people problem solve. And problem solving skills are a part of what we need to bring into health literacy and communication, especially for people that don't know how to do that don't know how to access the system, have the resources that are out there, and connect to community and all of that. So that's a big one. There was another one I can't remember, but if I do, I'll let you know.
Okay, thank you.
Len Lichtenfeld, Chief Medical and Scientific Officer for the American Cancer Society, not noted for brevity or conciseness, and I apologize. I'll do the best, and I'll try to focus what I'm going to say. I sat in this room a couple months ago, and we had a conversation around sustainability of the oncology workforce. I'm here today, and we're talking about literacy, and I assure you that this is not in my career. I've got gray hair. Ever since I went to medical school, they've been trying to teach me how to communicate effectively. I hope I learned something because I seem to have opportunities to do that, but a lot of my colleagues have not. I don't think that should be lost. So, it's rising on the radar screen. And then in a couple of months, we're going to be in here talking about SDOH. And Gwen, I want to make a point to what you just said. I was here in D.C. giving a talk over, happened to be in the Senate office building a couple of weeks ago, and I made a statement which I really firmly believe in. SDOH frequently is couched in terms of us and them. We don't have SDOH problems. They do. Well, guess what, folks? And you pointed out very eloquently, anybody in this room included could have SDOH issues tomorrow if they had a diagnosis of cancer. And I think we have to keep that top of mind that we're all in. But I'll tell you what really is frustrating me and has frustrated me through my career. I've sat in so many places with so many ideas and so many, and this is no exception, really terrific comments from really committed people. And I keep asking the question, so what are we going to do? The lung cancer example is really top of mind for me from a personal experience I had with a friend several months ago who was theoretically capable of being an activated person and fell through the cracks. I am no longer comfortable with having conversations between physicians. I think we need to have it. I think the failure, for example, in biomarker testing in lung cancer is a key example. Immunotherapy testing is a key example. And unfortunately, in this country, it's not happening. So I think at some level, and I know that this is really the big, audacious goal that will not happen, I think we need to take a look at the entire cancer journey. I think we have to talk from prevention to activation to diagnosis to treatment to survivorship, and we have to talk about end of life. We have to map it out. We have navigation. Perhaps we need, I call focused or precision navigation. We need to identify people in need, and we need to be able to meet them where they are with information they understand and make sure that they, to the point that was also well made, that they get the care they deserve, the disease that they have. And so happens lung cancer is top of my list because it's the leading cancer killer. I think we have to change our philosophy. The long conversation that I don't think I have time for here, our philosophy with stigma and everything else, and get past it and move on and understand we have huge opportunities. But all of the elements we've talked about here over the last 2 days are critically important. All of the elements we talked about in the previous meeting I referred to about sustainability of workforce with docs and health professionals and teams that are under incredible amounts of stress to do so many things that so many people in abstract say we need to be doing, and the kinds of things we're talking about at SDOH. We need a national plan, a national commitment, and a national engagement at every level, including the community level that you've so well articulated here and elsewhere. So that's my concise comment. I apologize for taking the time, but I really think it's something we need to pay attention to. How are we going to take this? How are we going to make it actionable? And how are we going to make it comprehensive? So we finally maybe take one place and start and say, what do we do to make it better? Because we have the pieces, we know where the issues are. How are we going to have the leadership? We've got the tools and the medicines. We know what we need to do. How are we going to make it happen? So I thank you for your indulgence.
Well, thank you, and I'll tell you, it was a wonderful segue into the final hurrah as we close out our panel. And so taking the question, what can we do, what can we chunk off? Because I think that's illustrative of health literacy, is that you deconstruct and you just figure out some very simple tasks that you can move to that journey and to that final outcome. We have been asked by the Academy to be bold in our actions and our recommendations and our suggestion. So what can we do? So if you have one item to contribute to the table, we'll go down the row. Should we start down at your end first? Okay.
I would start with, actually, from a policy sort of perspective, I think, and someone sort of said it best, is that you can't do it alone, and yet most of our policies still allow us to do it alone. As a result, someone mentioned the breast cancer task force from Chicago. The truth of the matter is that didn't happen because one academic institution felt that it was important. It was really a citywide sort of approach. Recently, we've actually recognized that we're doing much better in lung cancer screening because we're taking precision data that belongs to the community and getting them motivated in part. And so where traditionally National Cancer Screening Trial, you're getting 300, one cancer for 300 screens, we're getting down 3 to 4. We published that in JAMA Onc. So to me, this game cannot be won by just one bright academic institution or one bright whatever institutions. Where's the policy that sort of says if you're going to do something and it's actually going to impact X, Y, and Z, that it needs to be a team?
Personally, I would challenge everyone here and those listening to think about the ways that you can take the research that you're doing and broaden the applicability of it, so that take what you learn from doing your research and make sure that you share it with the community. If you're a physician, make sure that you're talking to regular people on the street, kind of the Dr. Lisa model, that you think about ways that you can work with other organizations, other institutions, and because together we can do a lot more and share a lot of best practices that maybe were learned in one cancer type or even in other chronic diseases, and apply it so that we can really make use of a lot of what researchers are doing every day in terms of finding results, instead of just for that one applicable place. Where can you spread that knowledge? And as patient advocacy groups, how can we reach across those lines? As industry, how can we work with industry partners on things to make our system a more patient-centric system, and think about the impact on patient and caregivers and how we can really take best practices and health literacy and psychosocial research that we're doing and really make the cancer experience a less overwhelming and individually impacting experience.
Margie.
I was going to say yes. Both of you. I think going back to the cultural piece is understanding, trying to define and come to some national consensus. Is health a human right, or is it a commodity that's based on money? And right now it's the second. We're trying to advocate for the first. A colleague of mine, Roberto Luis Fernandez, some of you may know him in New York, he said when we were writing up the definition of culture manual, he said he came in and he was so angry because the DSM-5 was being revised yet again, or it was going to be. And he said, are we asking for a revolution or a transformation? And I think that as a body here, we need to think about, and how do we move the needle and these incremental tiny things when we've got so many different objectives is not going to work. I mean, we'll all be dead by then. So how do we take that idea and move it effectively, efficiently, and distribute the good across all? And a friend of mine said there's the stool, three-legged stool. We do need the research. We need the community voice, because that's where the wisdom is and the knowledge. And then the policies to enforce that. And you can't do it without all three.
That's for sure.
Okay, trying not to be repetitive. So I think remembering that this conversation has to continue after we adjourn today, that we need to continue to connect with the friends and colleagues that we've made here today. We've all been exchanging business cards and having these great sidebar conversations. They have to continue. We all sit in a place where obviously this issue is relevant at some level. So figuring out what you can do from the place where you are currently sitting and how you can help move the needle from where your current vantage point is. And if you have trouble, or if you need help, or if you need to remember you're not alone, reaching out to the folks that we've been talking to for the last day and a half.
Okay. Anyway, there's just so many places to start, but I think that basically we can't forget that health literacy is to facilitate access to quality, affordable health care and equitable health care. And that has to be the foundation for everything that we do. And I think that one of the ways of being bold is to tackle something that we could actually do, rather than coming up with these big, bold, hairy ideas. And as Len said, we've been talking about this for a long time. Len and I have known each other for a long time as well. So one of the things that I've been working on a lot, and our team has been working on, along with a lot of other organizations throughout the country, including Rob Winn's organization, are skilled communications workshops to facilitate not just conversations about cost of care, but solutions to what the barriers are, what the cost barriers are to getting care. And I think one of the things that happens often in health literacy in these conversations in rooms like this is we talk about giving patients the words that they need to communicate, and that is absolutely the opposite approach that I believe we should take. What we have to do is facilitate a conversation that helps both parties and every stakeholder in having a communication that they understand each other. We don't need to give people words. We have to understand the words that people are saying. So I would say let's start with one issue that we can work on that works across this idea of empowering. We should say ask, listen, act, empower, and educate and empower, that facilitates access to care. And cost is a place to start, and cost is a place where I think we could actually be quite successful if we look at it across this continuum from a conversation to a solution.
Wow, there are so many ideas. I'm going to just share two quickly. I think health literacy is not a field that's owned by a particular group. It is something that we all are invested in, even if you don't consider yourself a health literacy researcher. I had this exercise with a lot of PIs who wanted to know, is this the right PAR for me? And we would do this exercise of taking out the word health literacy and see if you can still tell me what you want to do. And what I learned from that experience, there's cancer health literacy, genetic literacy, financial health literacy. There's so many ways to think about it. I think at the end of the world, at the end of all of this, or the end of the world.
Oh my gosh.
That's a Freudian slip. The partnership between practitioners, whether it's clinician researchers, social scientists, nurse researchers, people who are on the ground doing the work, and people who know how to understand a phenomenon, that partnership needs to continue to be strengthened. So I encourage all of you who are writing grants to examine your team composition and see, do you have an adequate representation of this true multidisciplinary, insights from different, especially patient perspectives on your team. It's not just data mining to see what patients have said on Twitter and then going back and then do your intervention. It's engaging them throughout the process of research. And the last point I would say is I feel like it's often this contrast between doing big structural changes, which tends to be very top-down, and the things that we're talking about ascertaining, listening to patients. I would challenge us to think about how do we do big, bold structural change that incentivize humility and listening. So that could mean a grant that's looking at how do we do the best job at really eliciting patient concerns. Or it could be some ways of not just going with, I think PRO is one way, really getting the best patient-reported outcomes. But I think that's one way. That's a quantitative approach. We also need qualitative approach so that we put humility and listening first in all of our intervention design.
Okay, I think our panel has said everything. Thank you.